Hi, everyone. I'm Nishi Shah. I'm one of the newer faculty members here at Emory, and I'm happy to present you some exciting data about bispecific antibodies. Um, so, Dr. Nuka talked about this a little bit, but bispecific antibody is basically a new form of treatment in myeloma where the drug acts like a matchmaker in trying to bring the body's immune cells, the T cells, to the myeloma cells. So there are different types of bispecific antibodies depending on the target on the myeloma cell at the moment. And there are three main targets that we have in pipeline. First is B-cell maturation antigen. We have three FDA-approved products, bispecific antibodies that target BCMA. There is another one that targets GPRC5D, which is talquetamab. And then there is another one which is in pipeline that targets a protein called FcRH5 on myeloma cell. So how do bispecifics work? So they work a little bit similar to CAR T cell, except that in CAR T cells, you are genetically modifying the T cells. In bispecifics, you basically are having a drug that brings your body's own immune cells to fight the myeloma. But essentially, it forms this synapse where the T cells are brought close to the myeloma cell and can kill the myeloma cell. And while doing that, it releases byproducts, inflammatory cytokines that can cause certain side effects which are specific for immune therapies. Cytokine release syndrome, which causes usually flu-like symptoms in patients, like fevers, blood pressure changes, oxygen requirements occasionally. And these cytokines can cross the blood-brain barrier and cause some neurotoxicity, which can cause occasionally confusion or fogging or other side effects. So what are the advantages overall for bispecific antibodies? Essentially, it's unlike CAR T cells, these cells are already you just give an injection or an IV medicine to the patient, and the drug will do its job to try to kill the myeloma cell. So it can be given fairly quickly should a patient require it. It is convenient to administer. It's either sub-Q or IV, depending on the drug. And it was initially studied in an inpatient setting, but now we are able to administer this outpatient. So it's very convenient for patients where they don't always need to be hospitalized to get these bispecific antibodies. And it's potentially something that can be widely available to patients who are not living close to a huge academic center because it's off the shelf and can be given in a clinic. So it has a wider availability overall in the community. Like I mentioned, cytokine release syndrome and neurotoxicity are some of the side effects we see with all bispecific antibodies. Usually for bispecific antibodies, these are mild, what we call grade 1 or 2, that are seen in most of the patients. Rarely do we see these side effects that require significant interventions or requiring a patient to go to the ICU. It's extremely rare for that to happen with a bispecific antibody. Neurotoxicity, again, is very rare, like 3 to 10% in patients on different trials, and it's also very low grade overall, where patients are able to, they don't need interventions that require them to go to the ICU typically. So there are currently 4 FDA-approved bispecific antibodies that we have for myeloma. 3 of them target B-cell maturation antigen, and 1 of them targets GPRC5D. So I've just listed them numerically, like based on the time of FDA approval. With 3 bispecific antibodies that target the same antigen, BCMA, this is frequently asked, like which works better, which doesn't. It's hard to compare these drugs one to the other because they were not studied head-to-head, but this data is based on the trials that we have that led to FDA approval. So the response rate for teclistamab, elrantamab, and linvoseltamab is somewhere in the 60 to 70% range. Very good partial response or better, which is typically when you see like a response of more than 90% improvement in a patient's myeloma protein is seen in majority of the patients who are responding. The time to response is usually within a month. So if we've started this drug on a patient, we would know within a month typically whether they are responding. We would try to keep it going for at least a month prior to switching to something else. Should there be a concern that somebody's not responding to the drug, we would still try to keep it going for at least a month because it takes so long for the drug to work. The median duration of response, again, this can be tricky because different studies have come out at different time points, so the follow-up for each study is different, but the median duration of response for example, teclistamab, which has data for a long, which was the first FDA-approved product, so we have a longer follow-up data for that, is 24 months. For elrantamab, on the latest data that we have, the duration, most of the people are still responding, but it could also be because it's a shorter follow-up. For linvoseltamab, it's about 29.4 months. The median progression-free survival, which is the time from the start of giving the drug to either patients progressing or dying from any cause, is about 11.4 months for teclistamab, 17.2 months for elrantamab, and hasn't been reached for linvoseltamab. And we also have some overall survival data. So, this is in general for the entire population that was studied. It's notable here that these drugs were studied for patients who've gotten more than 4 lines of therapy. You can see median prior lines of therapy. These are patients who've gotten 5 prior lines of therapy, 8 prior lines of therapy, and this drug still works in a significant proportion of patients. So that is very promising that we have this group of agents that are working so well in heavily pretreated patient population. And anytime we see that, we try to study this drug early on to see whether patients can do even better if this drug was introduced early. So these drugs are being studied at an earlier line of therapy. I'll get to that later on. Now, in terms of who responds better, are there any predictive factors that can help us understand, hey, that this patient will do better on a bispecific antibody versus they may not have such a good response? This is being studied more and more, but based on the data that we have already, potentially somebody who has a high disease burden or has myeloma in what we call extramedullary myeloma, where myeloma is outside their bones involving different organs, for example, or presenting as lymph nodes, which is not typical for myeloma, or say skin, those patients potentially could have a lower response as compared to somebody who has the typical manifestations of myeloma. If somebody has a high disease burden, meaning that they had a lot of myeloma cells in their bone marrow prior to getting this drug, it's possible that they have a lower response rate. It doesn't mean that these patients may not respond. It's just that if you were to look at probability, there's probably a slightly lower chance of them responding as compared to somebody who doesn't have these characteristics. This is based on data for teclistamab and elrantamab. So how are these drugs given? So teclistamab is given as a sub-Q injection. It's given, the FDA label says that is because of the cytokine release syndrome and neurologic side effects, we try to introduce this drug in a slow fashion, in a ramp-up fashion. So I usually tell my patients that we give like a baby dose. On, say, day 1, we watch them for the next 2 to 3 days. It depends on the setting. Some patients may not have a caregiver and are hospitalized for this drug. In those cases, we try to give this drug 48 hours apart. If somebody is getting this as an outpatient, which is what we typically try to do, we give it on every 3rd day. So, but typically we give a baby dose. We make sure patients are doing okay in the next 48 to 72 hours. They do not have any fevers, any other side effects. If they do, we can treat it very well based on some of the clinical data that we already have with drugs such as dexamethasone or tocilizumab. You get like a teenager dose on day 4 or day 3, depending on the setting. If they are doing okay with the teenager dose, then they get the grown-up dose at day 5 to day 7. Typically, after most of these side effects of CRS and neurologic toxicities are going to happen early on in this ramp-up period. So if patients are doing well and do not have these side effects in that early ramp-up period, we don't anticipate that they will have CRS and neurologic toxicities later on. This is something we worry about should a patient have a big gap in their treatment. If they have been started on teclistamab or any of the other medicines, and we had to hold the drug for more than a few weeks or a month or longer due to any potential side effect, that's when we would think about like, hey, do we need to give it again in a ramp-up fashion, or can we start it back at the dose that they had tolerated last? FDA has given us on their packaging insert, as well as in clinical trials, like we have studied like, hey, which are the patients who will benefit from a ramp up again, should they need a reintroduction of the drug in the future? So we know that pretty well. Overall, when this drug was studied, it was given in a weekly fashion. However, as we are using the drug more and more, we are adapting our practice and changing the frequency of administration, sometimes to every 2 weeks, to a month, or every 8 weeks, depending on patient's tolerability, as well as how well are they responding and how deep is the response to the different bispecific antibodies. Elrantamab is also given in a sub-Q fashion. So this drug is given quite similar to teclistamab, where you have like a baby dose. If they're doing okay, you get the second dose about 2 to 3 days after. If they're doing okay on the teenager dose, then they get the full dose at about 5th to 7th day. And then it's a weekly dosing. If they are responding well, we typically quickly change over to every 2 weeks to even a month sometimes for patients, based on some of the emerging data that we have, that this drug can still work at a lower frequency of administration. Linvoseltamab, which is the newest FDA-approved BCMA-targeted bispecific, is given IV. And this one has a different ramp-up schedule, where it's given on day 1, and then about like a week after on day 8, and then again a week after, you get the full dose. And then it's on a weekly schedule. Later on, again, you can switch it over to bi-weekly or every 4-week dosing over time. Talquetamab, which is the GPRC 5D directed bispecific, is also given sub-Q. It has 2 different labels in terms of administration of the drug. It can be given weekly or bi-weekly. Again, depending on how patients are tolerating, we do change the frequency of administration. Responses to different drugs. So overall, we talked a little bit about response to the BCMA-directed bispecifics with teclistamab, elrantamab, and linvoseltamab, where you have a response rate of 60 to 70% in different studies that were used for FDA approval. For talquetamab, this is a slightly busy slide, but like overall, the response rate is again like somewhere close to 70% for talquetamab. We have seen, based on the data, it was studied in 2 arms, actually 3 arms. One is weekly, one was bi-weekly, and then one cohort was specifically studied for patients who've received previous T-cell directed therapies like CAR-T or other bispecifics or so on and so forth. So in this group of patients, overall, still the response rate is close to like 70%. And potentially, the data suggests that the responses are more durable in patients who are getting the bi-weekly dosing rather than the weekly dosing. Overall, the median duration of response was like 9.5 months for the weekly dosing, which is 0.4 milligrams per kg, or in the bi-weekly dosing, it's about 16.9 months. The exciting part about this drug is that even in patients who have received previous CAR-T or bispecifics that target other agents, we have very good response rate overall that we see for this group of patients. We talked about how well these drugs work and what are the response rates. So what are some of the side effects? We talked about one group of side effects, which is very specific for immune therapies, which is cytokine release syndrome and neurologic toxicity. Some of the other side effects that we specifically see for this group of patients is that patients can develop hematologic side effects where they are getting neutropenic or having lymphopenia, white cell count is going down, or have thrombocytopenia or anemia. These patients are particularly vulnerable to infections. So that is something which we are learning to change our practice for, like an adapt guidelines, so that we can do our best to prevent infections for patients who are on bispecific therapies. But essentially, here what I'm trying to show is that in terms of infections, grade 3 or 4 infections, which is when patients are needing acute intervention to manage their infections in a very close monitored setting, can happen in about 40 to 50% of patients for BCMA-directed bispecifics. For GPRC5D-directed bispecific, infection rate is seen lower. So for talquetamab, we don't see as much infection as we see for the BCMA-directed bispecifics. So what can we do to prevent infections for patients who are getting BCMA-directed bispecific is the question. What are some of the things that we have learned over time to prevent infections for patients? We'll get to that, but this is just another way of showing the incidence of infections for different bispecifics. So you can see that patients who are getting BCMA-directed bispecifics are having infections that have been going on over time, like while they are on the bispecific. For CAR-T, we have data that shows that infections are most common in the first 100 days after getting the CAR-T. But for bispecifics, we see that over time, while they are on the bispecific, infection risk is something that stays persistent over time. So we have come up with different guidelines to prevent infections for patients. So what do we do? Like typically, we do not give bispecific if somebody is showing signs of an active infection overall. We will screen them for hepatitis, HIV, to make sure that they do not have any active signs of these infections, because if they could potentially develop serious side effects if these infections are not properly treated already. CMV is another group of infection that we have seen with bispecifics. Like CMV infections can present in many different ways. Sometimes it can just present in the form of CMV being detectable in the blood, and we don't need to do anything. We would just monitor over time. Some patients can develop pneumonia or some of the other side effects from CMV. So CMV screening varies for different institutes, but typically we try to monitor it once a month or so to make sure that CMV is not detectable, and if it is detectable, that it's something we can, is it rising or proliferating in the patient in the setting of getting a bispecific. We will give prophylaxis for viral infections as well as for PJP for all patients who are getting BCMA-directed bispecifics. For all patients, typically, after they finish their ramp up and are on their monthly schedule, or after their first month of getting the bispecific, we give them IVIG to try to help fight any potential infection. We've seen that by using IVIG monthly, that typically the adverse infectious events have lowered in frequency. So we do that quite commonly for our patients who are getting bispecifics. if somebody is getting neutropenia or low white count from their bispecific treatment, we would give them some growth factor support to try to help them. One other thing that we do for this group of patients, and this is something that will evolve over time, is like as we are implementing this drug more and more over time, we have seen that there are some patients who are having infections or other side effects while being on the drug, despite all the preventative strategies that we can adapt. In those group of patients, we have held the drug, and even after holding the drug, we have seen that some patients continue to respond even after the drug has been stopped. So this is an evolving field. Like, is it possible that just by giving the drug for a limited or fixed duration, it's still going to have a durable response for patients for a longer time? Potentially, by doing a fixed duration, we could prevent some of the infectious side effects for patients, but still continue to have like a good myeloma response. So this is an evolving field, and we will know over time how we could adapt this. Every institute has potentially a group of patients where by giving them less frequent or fixed duration of drug, we have seen that some patients continue to have an ongoing response. We do not know who these patients are prospectively, so that is something that we will study over time so that we can adapt this in a more wider setting. One of the bispecifics that is being studied is cevostamab. It's not FDA approved yet, but that was studied in a fixed duration setting. There is a study for teclistamab also where it's being studied in a fixed duration, whether by just giving it for a fixed duration for patients who've had a very good response, whether they will continue to have an ongoing response over time. So more to come for this over time. I wanted to go back to one of the slides, which was for talquetamab. Now, this is the GPRC5D directed bispecific. So GPRC5D is a protein that we see on myeloma cells, but we also see that this protein is expressed on certain other cells like skin, nails. In some cases, we also see that it's present in cerebellum, like our brain. So there are some side effects that are seen with talquetamab, which are very specific for this drug. One group of side effects are skin-related side effects. Patients can sometimes have a rash or can have skin peeling. Usually we see that right after they finish their ramp up for talquetamab, that these patients could develop skin side effects. Typically, these side effects can be managed by making sure that the skin is hydrated well with different lotions, or by giving sometimes a steroid cream that we can manage skin-related side effects. Oral side effects, which is in the form of dry mouth or change in the taste or difficulty swallowing, can also happen. Again, we see this typically after they finish their ramp-up dosing and have started their weekly or bi-weekly dosing, that patients typically say that, hey, we are having, we're not able to taste or appreciate food as much. I had a patient once who had said that I cannot even taste my toothpaste. But over time, we do see that as we go less frequent with the drug, like say go from weekly to bi-weekly, or we adjust the dose to half the dose, that these side effects can also improve over time. We also adapt some other strategies like giving artificial saliva to some of these patients who are having dry mouth or difficulty swallowing, that helps. And typically, this side effect usually does improve over time as well after the first 1 to 2 months. The other side effects that we see typically because of dysgeusia, impaired taste, is that patients are not eating as much and they do lose their weight. And that's something that I actively tell patients right on, that, hey, we need to make sure that your nutrition is well taken care of while we start this drug. The last thing we want is patients to lose their weight while they are getting talquetamab. Sometimes patients can have nail-related side effects as well. But typically, those can also be managed and do get better over time for patients. We talked about this already. So we talked about different bispecifics. Now, I also told that there are some group of patients who may not respond so well to the bispecific, say patients who have what we call extramedullary disease. So there are certain combinations of bispecifics that are also being looked at, like, hey, so this is combining teclistamab and talquetamab. So you have two bispecifics that target two different proteins on the myeloma cell. So this is combining these two drugs together to see that, hey, can we improve response rate especially for patients who potentially may not respond as well to a single agent. So this was a trial that was studied, and I am showing data only for patients with extramedullary disease, but this group of patients had an amazing response rate with the combination of the two bispecifics. This is a combination that is being also adapted into clinic over time. We have used this ourselves in some group of patients with high-risk features where we potentially think that one bispecific may not work as well as giving a combination. More to come, but this is potentially a combination. The main thing we worry about by giving combination of two different bispecifics together is to watch out for infections rate. It seems, based on the data that we have so far, that infectious complications are similar to that seen in patients getting BCMA-directed bispecific. So we'll see over time how this combination gets adapted. So what are some of the other things on the horizon? So there are some other drugs in the same class, some other BCMA-directed bispecifics that are being studied, as well as other bispecifics targeting GPRC5D that are in the pipeline. I talked a little bit about cevostamab, which is a different target. So potentially patients who have progressed on BCMA-directed bispecific or GPRC5D-directed bispecific could have a response to this drug as well. Dr. Nuka alluded to this, but there are trispecifics also in the pipeline where we are targeting two different protein on the myeloma cell as compared to one protein on the myeloma cell. So there are two of these trispecifics that there are many, but there are two that are in clinical trials currently that show significant promise. Both these trials are going to be open at Emory soon. What are some of the other things that we are studying is trying to see if bispecifics work so well in patients who have had 4 different prior lines of therapy. How well do they do if they've had it early on? Some of the the pivotal trial for teclistamab did show that patients who had received less than or equal to 3 lines of therapy probably had a better response as compared to somebody who had 4 or more lines of therapy. So it's possible that by moving this drug early, that the T cells, the immune cells, are less exhausted and patients could have even a better response. So that is being studied in multiple different trials. Here I'm just talking about the 2 trispecifics that are being studied. So this is in group of patients that have been heavily pretreated with different drugs, including bispecifics, CAR-Ts, other T-cell engagers, or BCMA-directed bispecifics, say belantamab. Patients who have extramedullary disease or high-risk cytogenetics, we see that these patients are responding to the trispecific. So more to come on this. Same thing for the J&J trispecific. We do see that these patients are responding very well, even in patients who have received previous drugs targeting the same protein. So here we see data for say BCMA-directed bispecific that the patient had received previously, or GPRC5-directed bispecific. Even in those patients, the trispecific seems to be working. They show lower response as compared to somebody who has never been exposed to this group of drugs, but we still see that this drug can work. Bringing this therapy early. So bispecific antibodies are being studied in combination, different combinations, whether studying it with other known myeloma treatments like, say, daratumumab or Revlimid or even proteasome inhibitors, like that's being studied for patients in the newly diagnosed setting. We are trying to study bispecifics as maintenance therapy for patients who have received stem cell transplant too. We are studying it in early relapse in the first to 3 lines of therapy. So at Emory, we have multiple trials for this group of patients as well. Here, I'm just listing some of the trials that are ongoing for different combinations for myeloma. So here you can see like teclistamab is being studied for patients not eligible or even for patients who are intended for transplant. Both these settings are being studied, same for elrantamab. There are some trials where we are trying to do a risk-adapted approach, like trying to give the bispecific in patients who are not getting the best response from their quadruplet. So there are different settings that are being studied, and it's very exciting to try to bring this combination of drugs or even as a single agent in an early line of therapy and see how well do patients do. And so when we have so many new medicines and some of them have the same target, so what is the best sequence of different medicines? We have different immune therapies with same targets. We have different types of immune therapies available. So what is the best sequence that we should be using is also something that is actively evolving over time, but potentially based on how the FDA approval is, as well as based on some of the basic science data, typically like trying to go for, say, a CAR T cell first and then bispecific later is potentially something that is being explored more and more, as CAR T is already approved in the second line, while bispecifics are approved in 4 or more lines of therapy. So we do see that patients who've had BCMA-directed CAR T cell may still respond to BCMA-directed bispecific over time. However, the response rate is going to be lower. Even for patients who have had one bispecific and are going to another bispecific, we typically see that they will respond better when the time from the exposure to one bispecific to the second is longer. We see that these patients respond better. Potentially, some of this is from the fact that the T cells are exhausted. It could also be some exciting data that is showing that patients who have gotten BCMA-directed bispecific may develop certain BCMA mutations, and that's why they are not binding to one specific bispecific, but some of them could potentially respond to a second BCMA-directed agent. So it's very exciting to see how the science will evolve over time and what would be the best sequencing strategy over time for patients. So more to come in this group of patients, but this is a very exciting group of drugs, and time will tell what is the best utilization of this drug and in which setting. So thank you, everyone.